only during labor, this is cephalopelvic disproportions. You know that the female pelvis is very important for the obstetricians. That's why we very detailed studied the pelvis from the obstetrical point of view. I want to talk you that the topic of my PhD was cephalopelvic disproportion. That's why this topic is very important for me, and I know this topic very well. Female and male pelvis, of course you know that we have sexual differences. And what is the difference between the male and female pelvis? You can see on this picture very clear that the male pelvis have a build, and our men have larger muscles, of course, and by the nature the female pelvis is good adapted to the childbirth. Of course, the female pelvis, particularly the lesser pelvis, and the main goal of each woman all over the world, of course, give the birth to their child. That's why the pelvis of female adapted to the childbearing and more wider than the male pelvis. You can see it clear on this picture. We have 4 forms of contracted pelvis. The first shape is like heart shape. This is Anthropoid pelvis. This pelvis is more specific for the male, and if we have such form of contracted pelvis at woman, it's like funnel-shaped pelvis with a contracted outlet. You can see clear that the first plane of pelvis in this Anthropoid form of contracted pelvis like a heart shape. The next form of pelvis is gynecoid. This pelvis is for the 41% of women. This is normal form of female pelvis is gynecoid. The next contracted form of female pelvis is Anthropoid. It's oval shaped. This is like jeans shape of pelvis. This pelvis has long, narrow and oval shape. It's Anthropoid. You can see in the literature that this is a jeans shape. Another one is Cephalopelvic shape. The incidence of this shape is not more than 2% of women. It's wide pelvis, and in this case we have contracted anterior-posterior diameters. Once again, we have Anthropoid pelvis, we have Anthropoid, we have platypeloid form of female pelvis, and normally we have usually gynecoid. This is not contracted form of pelvis. In forensic medicine, the application of medical and anatomical knowledge for the purpose of law, for what? The first, for the identification of human skeletal remains, usually involves the diagnosis of sex. That's why your knowledge about pelvis not important only for the obgyn. It's also important for the forensic medicine and for another specialities, because it's very important not from the medical but also from the law point of view. A prime focus of attention is the pelvic girdle because sexual differences usually are clearly visible. That's why during your examination of the patient you clearly understand that this is female or male. Even fragments of pelvic girdle are useful in determining of sex, but it's not important for the obstetricians, but it's important by the specialist in forensic medicine. On this table, you can clearly see the differences, the main differences between the male and female pelvis. General structure. The male pelvis, of course, thick and heavy, and female pelvis is thin and light. Greater pelvis is deep in case of male pelvis and shallow in case of female pelvis. The lesser pelvis, that's very important for the obstetricians. In case of male pelvis, it's narrow and deep and tapering, and in case of female pelvis, it's wide and shallow and cylindrical, normally, usually. Pelvic inlet. This is the first plane of obstetrical pelvis. In case of male pelvis, it's heart shape and narrow. You know now that one of the form of contracted pelvis is Anthropoid. In this case, the first positions of the fetal heart will be in anterior-posterior diameter, in this case of contracted pelvis. Normally, pelvic intract in females oval and rounded and wide. Pelvic outlet also is very important from the obstetrical point of view. In case of male pelvis, it's comparatively small, and in case of female pelvis, is comparatively large. What about the scallop spine? It's also very important for the obstetricians. In case of male pelvis, project further medially into the pelvic cavity, and in female pelvis, do not project as far immediately in the pelvic cavity and smooth. The main anatomical structure. Obturator foramen, acetabulum, greater sciatic notch, and sacral promontory. From my opinion, it's very important for the obgyn is sacral promontory, because during the vaginal examinations, obligatory you can investigate the sacrum, because it's very important in the prognosis of the labor. If a woman in a previous history had maybe sacral fractures or sacrococcygeal fracture, and she has deformations of their pelvic cavity and sacrum, maybe it will be difficult to have normal labor. That's why you're obligatory usually palpate during the vaginal examination, especially in a full-term pregnancy. In a male pelvis, the sacral promontory prominent, and in case of android pelvis, you usually can palpate and you can reach the sacral promontory and measure the conjugata diagonalis. Normally, you can't palpate the sacral promontory if you have a normal female pelvis, and that's why you can't measure the diagonal conjugant. In case of female pelvis, it's not prominent, and one more, you can't palpate the sacral promontory and you can't measure the conjugata diagonalis. On this picture, you can clearly see the main differences between the contracted and normal female pelvis. In case of a normal female pelvis, it's circular pelvic inlet, and the angle, the inner part of pubic symphysis, you can see the angle 40-45 degrees. In case of android pelvis contracted, you can see the heart-shaped pelvic inlet, and you can see an acute angle of pubic symphysis that is equal 50 or 60 degrees. What is pelvic diameters? Such conjugates from the obstetrical point of view. Size of the lesser pelvis important in obstetrics. Who had classes now know about these diameters, because it is the bony canal through which the fetus passes during a vaginal delivery. You can understand it clear. And to determine the capacity of female pelvis for childbearing, diameters of the lesser pelvis are noted radiographically or manually during a pelvic examination. Of course, usually we do it manually, and in a very, very rare cases, maybe in a very rare form of contracted pelvis, we use X-ray examinations. In our country, the X-ray examinations, you should have strictly indications for this procedure, because X-ray have influence on the fetus. That's why usually we do a pelvic examination manually. Pelvic inlet, you know that it's oval in a form. This is the main anatomical structure and the pelvic diameter of a pelvic inlet. Diameters of pelvic inlet. We have antero-posterior diameter, such as obstetrical conjugate 10.5 centimeters. Then transverse diameter of pelvic inlet is 30.5. And also we have two oblique diameter, which is measure 12 or 12.5 centimeters. We have three diameters of pelvic inlet. What about diameters of pelvic outlet? We have two diameters. Antero-posterior diameters anatomical from tip of coccyx, the lower border of symphysis pubis, you know that their sacrococcygeal articulation is mobile, and that's why we have 1.5 centimeters plus to this diameter. Normally it's equal to 11 centimeters. The obstetric anteroposterior diameters from the tip of the sacrum to lower border of symphysis pubis, this is such obstetrical anteroposterior diameter, it's equal to 13 centimeters. Because the coccyx moves backward during the second stage of labor, and in case of fractures or maybe inflammatory process in sacrococcygeal articulatio, you have the problem of the mouth of this this mobile. That's why maybe the baby have the problem during the second stage of labor. That's why it's very important to investigate vaginally the sacrum promontorium, sacrum cavity, and the coccyx. Diameters of pelvic outlet. We have bituberous diameter. It's equal to 11 centimeters. This is the distance between inner aspects of ischial tuberosities, and bispinous diameter, which is equal to 10.5 centimeters. This is the diameter between tips of ischial spines. You should know it very well. Of course, you should study it during your classes, and of course, each teacher asks you about it on exam. Please pay attention on these diameters. Also, we have special obstetrical diameters, anatomical anteroposterior diameter, or true conjugate. What does it mean? You can calculate it from the diagonal conjugate, or you can calculate it from tip of sacral promontory to upper body of symphysis pubis. It's equal to 11 centimeters. How can you measure the diagonal conjugate? This is the inner diameter, and you can do it only during the vaginal investigations. As I said before, it's impossible to reach the sacral promontory in case if you have the normal sizes of the pelvis. If this woman has contracted pelvis, you can reach the tip of sacral promontory and measure the diameter between the tip of sacral promontory and lower border of symphysis pubis. It's equal to 12.5 centimeters. If you minus 1.5 centimeters, this is their true conjugate, which we discussed before. This one, true conjugate, yes, from tip of sacral promontory to upper border of symphysis pubis. You can calculate one more. You can calculate the true conjugate if you know the diagonal conjugate. 12.5 minus 1.5, and you have 11 centimeters. This is the diameter of true conjugate. you can measure it only during the vaginal examinations, and this is the inner diameter of female pelvis. The true or obstetrical conjugate, this is the narrowest distance through which the baby's head must pass in a vaginal derimetry. This distance, however, cannot be measured directly during a pelvic examinations because of the presence of the bladder. Diagonal conjugate from inferior pubic ligament to promontory. Measured by palpating sacral promontory with the tip of the middle finger, using the other hand to mark the level of the inferior margin of the pubic symphysis on the examining hand. After the examining hand is withdrawn, the distance between the tip of the index finger and the marked level of the pubic symphysis is measured to estimate the true conjugate, which should be 11 centimeters or greater normally. On this picture, you can see the main obstetrical diameters and how to measure diagonal conjugate and how to calculate the obstetric conjugate. This is the main diameters of the female pelvis. This is the outlet, pelvic outlet. We have two diameters of the pelvic outlet. This is transverse diameter of pelvic between the ischial tuberosity. Its diameter 11 centimeters, and anteroposterior diameter of pelvic outlet. Usually we talk about 9.5 centimeters, but due to the mobility of the articulatio sacrococcygeal, we have even 10 centimeters, and it helps baby to normally pass through the vaginal canal. Transverse diameter is the greatest distance between the linea terminalis or other side of the pelvic. This is the diameters of pelvic inlet. I said you before that we have three diameters: anteroposterior, oblique, and transverse. Usually, if we have the normal process of the labor, the fetal head pass through the oblique diameter of pelvic inlet. What is contracted pelvis? What is this? We have two definitions. Anatomical definition: it is a pelvic in which one or more its diameters is reduced below the normal by 1 or more centimeters. If you do pelvimetry, and if you understand that you have the decreasing of diameters even by 1 or more centimeters, you have contracted pelvis. And also from the obstetric point of view, it is a pelvis in which 1 or more its diameters is reduced, so it interferes with the normal mechanism of labor. We have anatomical and obstetric definitions of contracted pelvis. Which factors have influenced and changed the size and the shape of female pelvis? Of course, there are developmental factors. This is maybe hereditary or congenital malformations of changing of the size and shape of female pelvis. Of course, racial factor. Of course, nutritional factor. Malnutrition results in a small pelvis. Vegan or vegetarians have more incidence of contracted pelvis than in case of a normal kind of food. Of course, sexual factor or hormonal disorders, as excessive androgen may produce android pelvis in case of hormonal disorders. There, for example, women with PCOS or women with the suprarenal gland pathology. When we have excessive producer of androgens, of course, they have changes of the shape pelvis and they have android pelvis. Of course, metabolic as rickets or osteomalacia, of course, has a very big influence on the changing of the pelvis. Trauma, disease, tumors of the bony pelvis, legs or spine, of course, have a big influence in a changing of size and shape of the pelvis. What causes developmental? Small gynecoid pelvis, small android pelvis, small anthropoid pelvis, small platypeloid pelvis, maybe the absence of one sacral such as Naegeli pelvis, absence of burrs sacrantale, this is Robert's pelvis, this is a congenital malformation of a pelvis. In rare cases, normally sacrum is composed of 5 vertebrae. In case of 6 vertebrae, we said about high assimilation pelvis, and maybe less than 5 vertebrae, for example 4, this is lower assimilation pelvis. In very rare cases, we have splitted symphysis pus like split pelvis. Metabolic, rickets or osteomalacia. Traumatic changes in the majority of cases is due to fractures. And neoplastic as osteoma. That's why during a vaginal examinations you should investigate all sides of pelvic cavity for diagnosing of maybe neoplastic or fracture changes due to a previous trauma. Of course, a very big influence have spine disorders to the changes of pelvic size and shape. What? For example, lumbar kyphosis or lumbar scoliosis. That's why it's very important to pay attention on girls during school time to determine in time the problems with the spine, and if it's possible, correct it in time, avoiding the changes of pelvic shape and the size in the future. Spondylolisthesis, what is this? The fifth lumbar vertebra with the above vertebral column is pushed forward while the promontory is pushed backward and the tip of the sacrum is pushed forward, leading to outlet contractions. Their lower limbs, the changes in the lower limbs also have an influence on contracted pelvis, maybe dislocation of one of both femurs, atrophy of one of both lower limbs, oblique and or asymmetric pelvis when one oblique diameter is obviously shorter than another, This can be found in neglect pelvis, scoliotic pelvis, and diseases, fractures, or tumors affected one side. It's very important to ask about the diseases in childhood in girls. You should ask about rickets. Is expected if there is a history of delayed working and dentition. In case of trauma or disease of pelvis, spines, or lower limbs, and bad obstetrics history if it's not primigravida, if she has her experience in a childbearing. Maybe obstetricians use forceps during a previous. Maybe she has a cesarean sections. What indications she had to this procedure? Maybe during problem in a labor process, or maybe she had stillbirth. It's very important, and this history can help you to diagnose contracted pelvis and maybe prognose the process of labor, of course, for avoiding a stillbirth and give her a live and a healthy baby. General examinations. What help you in a diagnosis of contracted pelvis? Please pay attention at gait. Abnormal gait suggestion abnormalities in the pelvis, spines, or lower limbs. Stature. Women with less than 150 centimeters height usually have contracted pelvis. Please look at spines and lower limbs. Maybe they short in a head or may have a disease or lesions. I told you about rickets. That's why you should examine a head, maybe a square head, changes in the form of head, rosary beads in the costal ridges, pigeon chest, and Harrison's, Salkins, and bow legs. This is the manifestation of ricks in which you should pay your attentions, and it helps you to diagnose a contracted pelvis. General examinations. Dystachia, dystrophy syndromes. The woman is short, stocky, have problem with the pregnancy, subfertile, has android pelvis. You can diagnose it during external pelvimetry, masculine hair distributions, and with history of delayed menarche. This woman is more exposed to occipital posterior positions and dystachia. What else? The woman with contracted pelvis usually had changes in the form of abdomen. Why? Because usually they have non-engaged head in the last 3 or 4 weeks before labor in case of primigravida, such as pendulous abdomen. You can see clear on the picture the changes in the form of abdomen, such as pendulous abdomen. Why? Due to the non-engagement fetus head. Normally, in the last 3 weeks, in case of primigravida, the fetal head start to engage. And maybe malpresentations are more common. These help you in a diagnosis of contracted pelvis. Of course, each pregnant woman having her pelvimetry. It is assessment of the pelvic diameters and capacity done at full-term pregnancy. Usually we do it when her first visit to her outpatient department, and then we evaluate also pelvimetry at 38 or 39 weeks of pregnancy. What it includes? It includes clinical pelvimetry, internal pelvimetry for inlet cavity and outlet of pelvis, and external pelvimetry for inlet and outlet. Usually we use pelvimetry. This is a special obstetrical instrument which can help you to do the external pelvimetry. It is of little value as it measures diameters of the false pelvis, toms, Rarco crossing pelvimetry can be used for external pelvimetry. We have three transverse main diameters. The first diameter is interspinous diameter between the antero superior iliac spines, between the spina iliac anterior superior. It's equal to 25-26 centimeter. This is interspinous diameter. The second diameter is intercristal diameter. It's between 28 or 29 centimeters normally, between the most far points on the outer borders of iliac crusts. Bituberous diameter can be measured by pelvimetry between the tubermembran of the femurs. It's equal to 31 from 32 centimeters. We have rules of 3 centimeters. The difference between each diameter plus 3 centimeters. If you know interspinous diameter, that it's equal to 25 centimeters, 25 plus 3, you can measure the intercristal diameter. If you know intercristal diameter plus 3 centimeters normally, you know bituberous diameter. This is such rules of plus 3 centimeters, it's easy to remember. In case of rickets, the interspinous equals or even exceeds the intercristal diameter. The next main diameter is external pelvimetry, such as external conjugates, which normally 20 centimeters. Internal pelvimetry is done through vaginal examination. This is diagonal conjugate. You should try to palpate the sacral promontory To measure the diagonal conjugate, normal it is 12.5 centimeters and cannot be reached the sacral promontory. Normally it's 12.5 centimeters. If it is felt, the pelvis is considered contracted, and the true conjugate can be calculated by subtracting 1.5 centimeters from the diagonal conjugate. This assessment is not done if the head is engaged. You should do it before the delivery, during the pregnancy. Usually we do it in a 38 or 39 weeks of pregnancy. What is cephalopelvic disproportions? What is this? Cephalopelvic disproportions is a disparity between the fetal head and the maternal pelvis. It means that the particular head is too big for the particular pelvis through which it must pass. Cephalopelvic disproportion, this is a physiological conditions which can occur only during the labor. Please remember, cephalopelvic disproportion, the disproportions or pathological obstetrical situations which can occur only during the process of the labor. It means that the particular head is too big for the particular pelvis through which it must pass. The main causes of cephalopelvic disproportion: contracted pelvis with the normal sized head, if we have the normal sized of fetal head, but we have one of the form of contracted pelvis. Another conditions, we have normal size of pelvis, but we have a large baby. The large baby, the weight of this baby is more than 4 kilograms, for example. And the last conditions, a combination of a large baby and a contracted pelvis also can lead to a cephalopelvic disproportion. Please remember, the cephalopelvic disproportions cannot be diagnosed before the 36 weeks of pregnancy. Why? Because before then, the fetal head is too small for comparison with the pelvis, but at 36 weeks, the fetus would have reached its maximum size. That's why it's impossible to diagnose these cephalopelvic disproportions in there before 36 weeks of pregnancy. There are 3 degrees of disproportion. Minor degree. Here, the head does not engage or pass through the pelvic brim, but it may be possible to push it through the brim. The head is at the same level with the anterior border of the symphysis pubis. In this case, if you have a good uterine contractions, you have good engagement of the fetus heart, and the head may be able to push through the brim. This is a good obstetrical situation. In case of moderate degree, here the head cannot be made to engage and the pelvic brim, and the head slightly overlaps the anterior edge of the symphysis pubis. In this case, you should end the labor process by the cesarean section. And in the measured degree, here the cat greatly overlaps the anterior edge of the symphysis pubis, and of course, you end the labor process with the cesarean sections too. There are 3 degrees of disproportions: minor, moderate, and a measure. This is such as Vasten sign. I repeat you, minor degree. The head does not engage or pass through the pelvis, but it's possible. Moderate degree. The head slightly overlaps the anterior edge of the symphysis pubis. You can see it clearly on the middle picture. And on the right picture, this is the major degree when the head greatly overlaps the anterior edge of the symphysis pubis. This is the positive Vasten signs. And in this case, of course, this is the indications for the ending of the labor with the cesarean sections. How can we diagnose the disproportions? Disproportions should be suspected in short primigravida. It is uncommon in multigravida women with a previous history of spontaneous vaginal delivery of babies weighing more than 3.5 kilograms. A pendulous abdomen should lead to the suspicion of disproportions. If at 38th weeks of pregnancy, the head cannot be made to engage. Non-engagement of the heads in a primigravida at 36 weeks in Caucasian is regarded as an obvious sign of cephalopelvic disproportions, but in African, the fetal head does not engage until the first week or even toward the end of the first stage of labor. The head can, however, be made to engage by the head feeding test. Diagnosis can be made by assessing the degree of overlap of the head over the pelvic brim at the symphysis pubis. And of course, you should assess internal pelvic and external pelvic. How can you do external pelvic? You can assess by doing the external pelvimetry, which we discussed before, and internal pelvis you can estimate doing their vaginal examination. Major and moderate degree of disproportion are delivered by elective cesarean section, as I said you before. Patient with minor degrees of cephalopelvic disproportion are allowed trial of labor with the aim of achieving vaginal delivery. Trial of labor. A test carried out in the presence of only minor degree of cephalopelvic disproportion to see if vaginal delivery will be possible. It is done in an equipped and staffed hospital for operative procedures in case vaginal delivery fails. Of course, the success of trial of labor depends on the effectiveness of uterine contractions, the flexibility or give of pelvic joints, flexion of the fetal heart, and the degree of molding of the fetal head. Ambulations and upright positions can be adopted to promote effective uterine contractions, cervical dilatation, and of course, flexions of the head. Progress of labor is recorded on a partogram. You know that the partogram, this is the graphical scheme of labor process. Progress of labor is recorded on a partogram. Continuous fetal monitoring is used to assess fetal well-being. The aim of trial labor is to ensure a successful outcome of labor if dilatation is slower and the head fails to descend despite good uterine contractions. The decision must be made whether or not to allow labor to continue. If at any stage during this labor the mother or the fetus is under stress, a cesarean section will be performed. This is a partogram. You can see clearly in a active, we have two phases, latent phase and an active phase. In case of latent phase, the dilatations of the cervix is not more than 3 centimeters, and in active phase you have the dilatation of the cervix is more than 3 centimeters until the full dilatation of the cervix, when the first period changed to the second period, and you have two lines, Inlet line and an action line. What does it mean? Inlet line represent the mean rate of slowed process of labor. It means the doctors should do something for their more progressive labor. And if you have the action line, you should do maybe some obstetrical surgeries for the ending of the labor. Normal labor is plotted to the left Inlet line, and in this case the women have normal vaginal delivery. On this picture you can see their labor in case of cephalopelvic disproportions. You can see a prolonged latent phase then primary dysfunction labor, and secondary arrest of descending of not engaged fetal heart, but a good this is a good contractions, but they are not effective. You can see secondary arrest of labor. This labor with CPD usually ended by the cesarean sections. What is the main complications of cephalopelvic disproportions? This is prolonged obstructed labor due to their fetus for a long period of time stay in a pelvic cavity due to the prolonged ischemia, maybe in postpartum period, we have vesica vaginal fistula and recta vaginal fistula. Rupture of uterus due to thinning of lower uterine segment. The complications of cephalopelvic disproportions, of course, this is birth asphyxia. Of course, it's ischemic brain damage due to severe birth asphyxia. Ascending infections if ruptured membrane occurs for a long period, maybe the premature rupture of membrane before labor starting, and of course it's high risk of ascending infections. Also hypostatic pneumonia and respiratory distress, maybe of the fetus, or maybe in case of cesarean sections we have complications in a postoperative period, and a venous thrombosis due to their ischemic changes due to the stain of a long period of time of stain fetus had in a pelvic cavity. This is all what I want to say you on this lecture. Thank you very much for your retentions during my lecture. Hope my lecture will be useful in your classes, and maybe it will be useful on exam. I wish you good luck, take care, and hope to see you by eyes on exam. Thank you one more for your attentions, and goodbye for today.